Today we are going to talk about COPD. This presentation was prepared by Dr. Aidan Baker, myself Jordan Holdaway, with help from our good friend Abdul. We are all residents with the Northern Ontario School of Medicine Family Medicine Program, and we have no disclosures or conflicts of interest. Model to guide us in the development of this presentation. We won't spend any time talking about it, but you can pause on the next slide if you want to read about it.
Our learning objectives for this presentation were taken from the 105 topics for the CCFP section on COPD. In short, they are having a clinical index of suspicion for COPD in those presenting with symptoms suggestive of it. 2, when the diagnosis of COPD is suspected, how to confirm it. 3, in patients with COPD, how to appropriately follow and monitor disease progression. 4, encouraging smoking cessation. 5, offering appropriate vaccinations. 6, in apparently stable COPD, offer appropriate inhaled medications. 7, who to appropriately refer patients with COPD to. 8, how to appropriately treat acute exacerbations of COPD. So what is COPD? It is a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases.
COPD is the 4th leading cause of death in the world. COPD is preventable and treatable, but it is not curable. The most common risk factor is tobacco smoke. However, indoor air pollution from homes heated with wood is also an established risk factor. This has been more commonly seen in developing countries and in homes with poor ventilation. Approximately 4% of Canadians are affected based on a self-survey.
Diagnosing COPD, the gold standard is spirometry, showing an obstructive non-reversible pattern with an FEV1 over FVC of less than 0.7. There are several suggestive physical findings which you can find listed below. There are also suggestive findings on certain investigations like hyperinflation, emphysema on chest imaging, decreased voltages and pulmonary pattern on ECG, as well as polycythemia on CBC. The severity of COPD can also be determined not only with spirometry, but with symptoms in the 6-minute walk distance, as well as the time taken to do it, fibrinogen, CRP, and white blood cell count. So for spirometry, as you can see on the example spirometry to the right, the obstructive pattern shows scooping.
The Global Initiative for Chronic Obstructive Lung Disease categorizes airflow limitation in COPD into 4 stages. Gold 1, mild, has a FEV1 greater than 80% predicted. Gold 2, considered moderate, has an FEV1 of 50 to 80% predicted. Gold 3, considered severe, has an FEV1 of 30 to 50% predicted. And Gold 4, very severe, has an FEV1 less than 30% predicted. COPD management can be divided into 2 categories. We have our day-to-day management in stable COPD and management of acute COPD exacerbations. The goal of our day-to-day management is to decrease the rate of decline in lung function and to minimize the frequency and severity of COPD exacerbations. If the patient is a smoker, the most important step in the management of COPD is smoking cessation. Other steps include appropriate PPE or avoidance of exposures, annual influenza vaccination, pneumococcal vaccination. It is important that these patients get both the Prevnar 13 and Pneumo 23. If the patient were to get Prevnar 13 first, they can get Pneumo 23 in 8 weeks. However, if they get Pneumo 23 first, they have to wait at least 1 year before they're eligible for Prevnar 13. Maintaining appropriate levels of physical activity and reviewing the correct inhaler technique are also important. Pharmacological therapy is used to improve symptoms, reduce the frequency and severity of exacerbations, and improve exercise tolerance. The decision of what medication to initiate is based on the severity of their COPD. To determine the severity, we have a couple of different assessment tools that we can use. Gold has developed the ABCD assessment tool, which is fairly comprehensive but not as clear-cut as the Canadian Thoracic Society algorithm, which classifies the severity of a patient's COPD and suggests medication classes based on this severity. If using the ABC assessment method, there's a nice table on UpToDate that helps determine the appropriate medication based on the patient's score. Both of these are validated and useful options, and both require you to also use either the COPD assessment tool or the modified British Medical Research Council questionnaire. We will review them both here, and you can pick which one to use in your practice. This is a COPD assessment tool. It is on MD Calc, making it quick and easy to access. The questions are graded on a scale of 0 to 5, with 0 being good and 5 being poor. It is about cough, phlegm, chest tightness, breathlessness, activities, confidence in being able to leave their home, sleep, and energy. The Modified British Medical Research Council questionnaire has fallen out of favor compared to the CAT, but can also be accessed through MD Calc. It is still valid and usable. The ABCD assessment tool was developed by Gold and grades people based on their FEV1% predicted and groups them using a combination of exacerbation history and either the CAT questionnaire or the MMRC. This helps highlight the importance of exacerbation prevention, but clinically may not be any more useful as it has been shown to be no better at predicting mortality than spirometry classification alone. Using the ABCD assessment method from Gold, I suggest referring to UpToDate to help guide you in medication selection. I've summarized one of their tables below. This algorithm is from the Canadian Thoracic Society. I find it very easy to follow and it guides treatment in a stepwise fashion. Of note, low risk is up to 1 moderate COPD exacerbation in the past year, while high risk is 2 or more moderate COPD exacerbations, or 1 severe exacerbation.
Another approach to management of COPD can be found by the Canadian Thoracic Society. This one is also helpful as it includes things like pulmonary rehab, oxygen, and looking towards surgery. I also like this diagram because it does point out the need for end-of-life care and palliative consultation compared to other algorithms which more focus on the pharmacotherapy of COPD. So below you can find a list of the options for pharmacotherapy that can be used as per the guidelines mentioned previously. These are all available in Canada. It should be noted when prescribing inhaled corticosteroids in COPD that they do result in an increased risk of pneumonia with a risk ratio of 1.59. They also significantly increase the risk of severe pneumonia with a risk ratio of 2.17. Interestingly, when subgroup analysis was done, it did demonstrate that fluticasone alone, but not budesonide, resulted in an increased risk of pneumonia. So just something to consider when choosing your inhaled corticosteroid, looking between fluticasone or budesonide. Moving on to COPD exacerbation. Initially, we will discuss the risk factors for COPD exacerbation. Those include advanced age, productive cough, longer duration of COPD, history of antibiotic use, history of previous COPD exacerbation, specifically COPD-related hospitalizations within the past year, chronic mucus hypersecretion, an elevated blood eosinophil count, theophylline therapy, and presence of comorbidities such as heart disease or diabetes. So how is a COPD exacerbation diagnosed? The most agreed upon definition is an acute event that is characterized by a worsening of the patient's respiratory status that is beyond normal day-to-day variation and leads to a change in medication. Typical symptoms to look for include increasing cough, either the frequency or severity, sputum production that increases either in volume or in character, and increased dyspnea. It's important whenever you're considering a COPD exacerbation that you also assess for comorbidities such as CHF, coronary artery disease, diabetes, and pulmonary embolus. In regards to management of COPD exacerbation, always the initial step is to assess your instability and to direct the patient appropriately, including to the ER if needed. If supplemental O2 is needed, it's okay to titrate to 88 to 92%, especially if there are known CO2 retainer. However, if there's no documentation of that, titrating sats of 88 to 92% is acceptable. There are validated scores to decide if admission is necessary, such as the BAP65 or the DCAF score. Again, going back to the 2 of 3 criteria, including increased sputum volume or a change in sputum, increased dyspnea, then antibiotics are indicated. We should always offer oral steroids. Initially, prednisone 40 milligrams was used in studies. However, since the pills here in Canada come in 50 milligram tabs, this is what we suggest to simplify medication dosing. It's important to consider switching from home medications to the short-acting equivalents, especially if they're being admitted. And as previously stated, if no infectious cause is found, consideration for PE as a cause of exacerbation is important. And as always, make sure you keep your differential broad to not exclude potential causes too early. So now that you've treated your patient with a COPD exacerbation, what should be done? First, reevaluation of home medication and compliance. You always want to assess if they have actually stopped smoking, and if they haven't, you want to provide them with the appropriate medications and help to do so. Consider age-appropriate lung cancer screening if a smoker. Again, in trying to reduce the risk of cancer, make sure they're having 7 servings of leafy greens to reduce their cancer risk. Connecting them with pulmonary rehabilitation as necessary. And before they go home, it would be important to consult RT to assess for home oxygen and to arrange for follow-up spirometry to assess for disease progression. To emerging research for COPD, there is much research going into biomarkers for tracking disease. The ECLIPSE study did find that there are several biomarkers that could be suggestive of COPD severity. However, none have gained recognized cutoff values, nor have target values been established. In regards to PE and COPD, high rates of PE and acute COPD exacerbation that were needing hospitalization were noted, with approximately 2/3 of the PEs found requiring oral anticoagulation. Further trials are needed to determine the prevalence of PE in COPD exacerbations not requiring hospitalization. Points from our discussion and presentation are the diagnosis with an FEV1 over FVC of less than 0.7 without reversibility, that monitoring of disease progression with symptoms and PFTs is needed periodically, that patients should be offered the appropriate vaccinations, that a chronic disease management model should be used, and that smoking cessation should be promoted at all junctures, as well as treatment goals should be decided between you and the patient.